Okay, I think we're pretty close to being at 10. Happy Tuesday, everybody. It's our last antimicrobial lecture. So yay, yay. We'll talk a little bit about exam questions kind of at the end, but I think I'll have like 12 total, so it kind of ends up being about 3 questions per lecture. So obviously with that like small number of questions and a lot of material to cover, the questions are a little bit complex, but they're all going to be things that we really went over and emphasized in class. So nothing tricky, straightforward things, okay? So don't panic, because I know how much material this is in such a short amount of time. So today we're kind of doing the catch-all kind of weird guys at the end. So some of the antimicrobials that we end up using for other purposes, but are still considered antimicrobials that we need to understand. So as you guys know, I like to start off with a little bit of recall from the previous lecture. So the first point or question here is antimicrobial drugs that inhibit protein synthesis are typically bacteriostatic. There is one main exception, and that is what class? One big class that we've talked about in the beginning of those protein synthesis inhibitor lectures that actually kills bacteria by itself. It doesn't just suppress growth. Aminoglycosides. I hear somebody saying that, and that's correct. Really good. That's different than the macrolides, lincosamides, and phenocols. They all inhibit protein synthesis also through binding of the 50S ribosomal subunit and are considered bacteriostatic. The macrolides and what other class are very similar in terms of spectrum of activity and toxicity. So when you're comparing lincosamides and phenocols, which one of those are more like the macrolides? Lincosamides, really good. They kill bunnies, remember? So hindgut fermenters, that really takes a hit on their hindgut flora, and they're more likely to die acutely from GI disease. The phenocols are very broad spectrum, and the prototype of the class is what big drug? Chloramphenicol, and it has the main important toxic side effect of potentially causing aplastic anemia in people and is banned in food-producing species, right? So that's really good. Those are really important kind of key concepts. And again, like for the exam, kind of thinking about what groups are similar to each other and how the different classes differ. And the main concepts that we talked about are going to be things that are definitely going to be covered, okay? Okay, so getting right into a new class today are the nitroimidazole antibiotics. Their mechanism of action is that they interfere with nucleic acid synthesis by breaking DNA strands and inhibiting DNA repair enzymes. They only are effective in doing this in anaerobic environments. And the main drug in this class is actually going to be metronidazole. So I bet most of you, that, especially if you have worked in a clinic or have dogs or cats, you've probably heard of metronidazole or have seen veterinarians prescribe metronidazole for colitis in dogs, so stress colitis, hemorrhagic colitis. Their main spectrum of activity is that they're bactericidal, And they're very broad against anaerobes, but ineffective in aerobic environments, okay? So they don't get aerobic bacteria, but gram-positive and gram-negative anaerobes. They also get some weirdos like Entamoeba histolytica, Giardia, Balantidium coli, Helicobacter pylori, gosh, I can't speak this morning, and Trichomonas. Their main route of administration is going to be oral. That's the way most veterinarians are going to use this medication. They're also bioavailable and absorbed per rectum. And we'll talk about why that is sometimes a preferred route of administration in some species. The other way that this is administered is intravenous, but that's more expensive. And of course, whenever you're giving an intravenous medication, that usually implies you need to have a catheter in place. And so that's going to be specific for hospitalized patients, but that's actually a route of administration in people with anaerobic infections, okay? Their disposition is that they're very lipophilic, so metronidazole you could expect to get into all the tissues, so into bone, into abscesses, crossing the blood-brain barrier. They have a high volume of distribution, which goes along with their lipophilicity, and primarily hepatic metabolism. This is all common things when you have a very lipophilic drug, that you need that drug to be transformed in the liver to then be able to be excreted either through the biliary system or some degree of renal excretion after it's been transformed to something more soluble in water, right? The main toxic side effects are usually pretty minimal at a standard dose. So horses, we can see inappetence even at a normal dose. And that is where the administration per rectum comes in, because the side effect of inappetence is less likely to occur when it's given per rectum. The metronidazole is extremely bitter, but in speaking with people that have had Flagyl or metronidazole given IV, they get a weird taste in their mouth even with the intravenous administration. So basically some metabolite of the metronidazole in the bloodstream kind of gives them that weird icky feeling or taste in their mouth. So it's possible that inappetence will even occur with other routes of administration beside oral. It's a carcinogen in lab animals, so I bet you're going to guess that maybe we don't use this in food animal species, and that's going to be true. And the side effects for neurologic disease are that they're usually dose dependent. So we don't usually see neurologic sequela unless you have high doses, overdoses, that kind of thing. The specific indications are for an anaerobic infection. So clostridial diseases are a prime example of a clostridial bacteria that would cause infectious disease. So sometimes we see myonecrosis with clostridial disease, colitis, hemorrhagic colitis, which is something that we see in small animals, right? That we don't always think we're treating a specific bacteria, but it has this other mechanism of action of causing anti-inflammatory effects in the GI tract through inhibition of leukocyte endothelial cell adhesion in the postcapillary venule. So in the GI tract, you're going to reduce inflammation that can actually contribute to reducing the inflammatory disease in the bowel. Of course, if we think that the disposition is that there's a lot of hepatic metabolism, the contraindication in this particular drug would be liver failure. You wouldn't want to give it in an animal that didn't have normal liver function. So remember, you can have liver disease and an infectious process in the liver, like cholangiohepatitis, without being an overt liver failure, okay? But in an animal that's actually in liver failure, where they're not able to metabolize things normally and there's abnormalities in their liver function test, that would give you pause before giving that animal metronidazole. Does that make sense? I know we kind of talked a little bit about when do we give animals with that have a potential for hepatic metabolism. When do we give those antimicrobials to animals if they have liver disease? And so there's a big spectrum of liver diseases, but true liver failure, you would not give them metronidazole. They are banned in food animals, as we kind of alluded to, because anything that's considered a carcinogen or that's really vitally important for human medicine, we usually do not administer to food-producing species. Okay, so metronidazole is really specific because this is really the only drug that we're talking about that has purely anaerobic activity. This is something to remember for the rest of your lives. I'm telling you right now. So this is the only antimicrobial that we use, that we give systemically, that is solely for anaerobic use. All the other drugs that have some anaerobic spectrum, like penicillin G has a good anaerobic spectrum. It is not as broad as metronidazole, but it also covers a lot of aerobes. So it's very different from metro. The same thing for chloramphenicol. It has pretty good anaerobic spectrum too, but it gets a lot of aerobes as well. So this is different, and you want to make sure you can distinguish that this is a special drug, definitely has a different spectrum of activity than any other drug we're going to talk about, okay? Okay, so now moving on to some of the weirdos. That's kind of the last, well, no, it isn't. One more that we give systemically for antimicrobial purposes. But we're going to switch over to the nitrofuran antibiotics. These have a similar mechanism of action, and so that's why I added them next. Historically, nitrofurazone was really only for, and it still is only for topical use. It used to be labeled to give topically in food-producing species, but because it also has carcinogenic potential in lab animals, it's not used for food-producing species at all. So only horses, it's actually on the label right here. It says for use in horses only and for topical application only. It's broad spectrum, but the main thing that it is not very good against is Pseudomonas aeruginosa. But otherwise, think of it as a broad spectrum topical antimicrobial. The mechanism of action here is also similar. It interferes with nucleic acid synthesis, so also causes breakage of DNA strands. This is a little bit different. It's rapidly eliminated through the kidneys when given orally, and the only drug in this class that we give orally is nitrofurantone, and this is really something that only the small animal side of the hospital uses, specifically for acute or recurrent urinary tract infections, especially if you're worried about extended beta-lactamase producing E. coli. So things that are going to be resistant to your beta-lactam classes, and especially those that are already resistant to the beta-lactamase, those potentiated beta-lactams, right? So we have things like clavulanic acid we talked about earlier on that protects the beta-lactam ring. And when you have bacteria that have already circumvented them and have found a way to break up those beta-lactamase inhibitors, this is a drug that is effective against those particular isolates, okay? It does not get systemically absorbed, so it really gets high concentrations in the urine, but would not be effective for an infection anywhere else in the body, because you're not going to reach systemic levels that's going to be effective against other microorganisms anywhere but in the urine. Does that make sense? So you give it orally, it gets absorbed in the GI tract and immediately, very rapidly excreted in the urine in high concentrations. Okay. Again, the toxicity is a potential carcinogen. There's dose-dependent dosing that can result in cancer. So carcinogen means possible to cause cancer, right? And there's cross-resistance with the nitroimidazole. So if there's some sort of resistance against metronidazole, there's probably also going to be resistance against this class as well. And you think about it, that makes sense because the mechanism of action is so similar, right? So here they break DNA strands. The difference with the nitrofuran antibiotics is they can work in an aerobic environment, whereas metronidazole cannot. Metronidazole only breaks strands in anaerobic environments, anaerobic bacteria. Okay, very good. So that's kind of a weird one, but you'll definitely come across that in the small animal clinic. And we'll use nitrofurazone topically in things in horses like sweating their limbs and dealing with topical infections in horses only. The rifamycin antibiotics, the main prototype of this class is rifampin. It has a very specific and special mechanism of action, nothing that you guys have had before, and it inhibits protein synthesis via DNA-dependent RNA polymerase blockade. Okay, so it can't replicate RNA, and you get a bactericidal effect. This spectrum of activity is, again, time dependent. And so if you guys remember time dependent, like this is a concept I've definitely talked about multiple times and will come up on your exam. So when you're thinking about time dependent antimicrobials, that is a drug that you want to have above the minimum inhibitory concentration of the pathogen for the entire dosing interval. So usually we're giving that drug multiple times a day to keep that level above that concentration that we've set by the lab, really. But it doesn't have to be really, really high in the plasma. It just has to stay in the tissues and in the plasma, the site of infection, for the entire dosing interval. The spectrum here is also pretty specific. It's gram-positive and aerobes and some anaerobes, but not very good against gram-negative bacteria. The route of administration is oral, and the disposition is highly lipophilic, so strictly hepatic metabolism. And the specific indication is that we use it specifically for treating abscesses, and especially abscesses with intracellular organisms. So the best example of that is the treatment of Rhodococcus E. coli in combination with a macrolide. The main reason it's in combination with a macrolide is that we are never giving rifampin as a monotherapy because the likelihood of resistance developing is very high, very rapidly, and it remains stable in those microorganisms exposed to it. So by combining it with other drugs, you avoid the rapid change to resistance. So it is added to other antimicrobial therapy for things that are difficult to treat, like abscesses, osteomyelitis, things where you really need a lipophilic drug to get into those sites. The toxicity here is fairly mild. The main thing is that it causes discoloration of bodily fluids, which doesn't really harm the patient, but sure could scare the heck out of your client. So if you send this animal home and it starts having bloody orange tears, they could really freak out. So it's really good to know what will happen when you give that drug to warn the owners what to look for and what not to worry about. So you can see red-orange tears, the urine and saliva can change color. And so that could be a problem that you can ward off getting an 11 p.m. phone call from if you just warn them that that could happen. It will also increase hepatic enzyme activity, so you'll get like a clinical hepatitis or clinical pathologic hepatitis where you won't have much of an effect on function, but you'll have evidence of increased hepatocellular cholestatic enzyme increases, okay? So we never administer this as a monotherapy. There's rapid antimicrobial resistance that occurs. And it's important to know that this is one of the drugs that's a potent inducer of microsomal enzymes in the liver. So that actually results in clinically increased excretion of certain drugs like steroids, ketoconazole, barbiturates, digoxin, and oral anticoagulants. So if your animal's on multiple drugs, you just want to know what the effects are on the patient. That might have to change your dosing frequency or dose or something like that, or monitoring, right? It might mean that you don't need to change the dose right away, but you need to monitor the patient for evidence of being more procoagulant if you're trying to keep them anticoagulated, that kind of thing. Does that make sense? Okay. So that really ends the last important class. Oh, yes.
I just had a question about the clinical hepatitis. Should you be doing like liver values before you start an animal on this drug? Like not starting it if they're already elevated?
Yeah, exactly. So well, that's a harder question to answer because actually rifampin ends up being a good drug to include if you've got like hepatic abscesses or something like that. But if you have mild evidence of like enzyme increases in the liver, but normal liver function, it probably does not make you worry too much about starting them on rifampin. But yes, that is something that we monitor while they're on the drug. And it will just basically cause mild increases in SDH and GGT in horses and maybe AST and ALP in dogs. But again, it's a clinical pathologic change doesn't usually cause any functional disease in the patient at the proper doses. But chronic therapy, if you're going to have them on for that for months, is more important to monitor than short-term therapy. Really good question. Okay, so now we're moving on to polymyxin antibiotics. These are true antimicrobials, but they're not used in the clinic systemically as an antibiotic. They're used topically as an antimicrobial, so you'll see that they're combined in like triple antimicrobial ointment for the eye or for the skin. And the main way that they have their effect against bacteria is that they disrupt the gram-negative membrane in a detergent-like effect. So they break up the cell membrane of those gram-negative bacteria, so it's pretty narrow spectrum. They're providing gram-negative coverage when they're combined in those topical ointments and drops in the eyes and things like that. But they also have a really cool other effect of causing binding to a specific portion of LPS, so lipopolysaccharide, which the molecule is synonymous with endotoxin. So endotoxin in all species, horses, cattle, dogs, they cause a massive inflammatory response. And even if there's not overt bacteria in the bloodstream, they can make the animal look like they're sick or septic, cause fevers, drops in the white count, and really severe signs of systemic inflammatory response syndrome. So in horses in particular, this drug is given intravenously at very small doses to bind lipid A, that portion of the lipopolysaccharide, so it cannot interact with the immune system and incite that inflammatory reaction. But it is not ever given at a high enough dose to actually cause any, to be effective as an antimicrobial in that sense. And the reason for that is that it is very highly nephrotoxic. So it's great because it's bactericidal on the skin, it has a narrow spectrum for gram-negative aerobes, but we're only giving it intravenously for that other anti-endotoxic effect. And I think on the next page, yeah, we'll talk a little bit more about what kind of cases we're using it for, but it's just important to realize it's not a parenteral antimicrobial because it has such a high potential for nephrotoxicity. So it's highly polar. You guys will remember that means it mostly stays in the water components of your body, so it's staying within the intravascular space or in the interstitial fluids, but not crossing into the tissues. And the main indication is really an equine colic or colitis, pleuropneumonia or metritis, anywhere where we're going to see a massive release of endotoxin into the bloodstream. The toxicity is dose dependent, and it's mainly nephrotoxic and can be neurotoxic at very high doses. And so we really are only using this in equine patients. It's not routinely used in small animal patients because of the potential for nephrotoxicity. We seem to have a lot more clinical problems with endotoxemia as well than the small animal side, and so we treat those things a little bit differently. Does that make sense? So this is purely a topical antimicrobial, narrow spectrum against gram-negatives, and then this other cool effect of being an anti-endotoxic therapy in horses with severe systemic inflammatory response syndrome associated with LPS in the bloodstream. Okay. The next class are the glycopeptide antibiotics, and the main reason to introduce this is so you recognize it and realize this is one of those things that we shouldn't be using routinely in the clinic. The main drug in this category is vancomycin. It inhibits cell wall synthesis, so you've heard of this before, right? Inhibit cell wall synthesis, it should make you jump up and scream, beta-lactams, right? Yes, everybody just did that in their heads, I know. So this does that, but a little bit differently by binding to the D-alanine cross-linkage site, which is a different place than where the beta-lactams bind, but it also does the same action of inhibiting cell wall synthesis, and so you'll get a bactericidal effect. It has a very narrow spectrum of activity. It's gram-positive aerobes only, and it's really used just for things like resistant staphylococcus, and was used for things like enterococcus, that's very difficult and sorry guys, gosh, I'm struggling this morning with finding words, but anyway, very difficult to treat enterococcus infections in the hospital, but what's emerging over the past decade is even vancomycin resistant strains of enterococcus. So really, and that's in the human hospital settings. So we really put this off to the side and get special exceptions to use vancomycin if we know that we have a specific infection that's not responding to current treatment, that is susceptible to vancomycin based on our antibiogram, and the animal is otherwise failing to respond to treatment that we started with, okay? It's not bioavailable, so we do not give this orally. It's only administered IV, and it can be used for things like regional limb perfusions to really get the concentrations of drug high in one specific area. We didn't talk much about regional limb perfusions here, but that will be something you'll encounter in the clinics. And of course, because it's so important to important infections in people, it's banned in food-producing species. Okay, so that was vancomycin, big gun, not routinely used, but recognize what it is in case it comes up either in the clinic or on boards. Okay, now moving on to the ionophore antibiotics. This is a really weird class. It has a very narrow spectrum of activity where it's very effective against gram-positive bacteria, and it's mainly used as a coccidiostat. Okay, so this is a drug that is used in food-producing species, but for a weird reason. The mechanism of action here is to disrupt cell membrane channels. So it actually causes potassium to be exported out of the cells and causes the import of hydrogen into the cells, results in a pH drop in the cells and cell death. The main reason this is used in food-producing species is to alter the bacterial population of the rumen, to push them more towards propionic acid, which is a more direct precursor for gluconeogenesis, so they could get bigger and fatter and more delicious faster, basically. So it's more efficient for glucose metabolism. It's a growth promotant in that sense. It also reduces the risk of developing fog fever when put out on pasture, and it causes reduces the risk of how the bacteria basically reduce 3-methylindole from tryptophan. So it's trying to, it can protect them from getting fog fever, which again is basically an atypical interstitial pneumonia. They get emphysematous and they're in respiratory distress, and that usually happens from a sudden change to lush pastures when you put cattle out on lush pastures that are not used to being out on grass. So pre-treating them with a coccidiostat before you put them out on the pasture would reduce their risk of fog fever. That's one good way to think about that. It is labeled for food-producing species to increase feed efficiency and prevent and control coccidia, but they're definitely very toxic, and they can be toxic to ruminants as well at really high concentrations. But in horses, they're very toxic at low doses. So they're cardiotoxic, and they can cause colitis at a very low dose of 2 to 3 mg per kg. And the main way horses get exposed to this is through mixing errors in feed mills. So they get accidentally, their feed gets mixed in a similar silo as what had just been mixing cattle feed, where they were mixing ionophores in, and that is one potential way they get exposed. This is something that's a great boards question. It comes up all the time, and it's a rare thing that we see in clinics to see a horse that's got an ionophore toxicity. But it's worth mentioning because you probably won't see it anywhere else, and it is an antimicrobial, okay? Okay, so now we're kind of done talking about most of the important classes of antibiotics. We're gonna go through a little bit of some, things to remind you about when using antibiotics in the clinic, and kind of talk through some cases, some case examples that we might go through. They probably won't be as complicated as what I'll do here, but similar types of questions or thought processes for exam questions. Okay, so when we're trying to kind of group antibiotics together for like things that are similar about them, the antibiotics that we've talked about so far that are reserved for highly resistant bacteria and are very important for human medicine are the imipenem-cilastatin combination, which is a beta-lactam, It's a carbapenem. So the carbapenem, like subset under the beta-lactams, we're not using routinely in the clinic. And when you combine it with cilastatin, that is a potentiating agent, right? That is a beta-lactamase inhibitor. So it makes that drug more broad spectrum against gram-negative bacteria. So it is like a powerhouse. It's going to kill a lot of bacteria. It's very good against most resistant things. So when you get your culture back and your sensitivity results and it says R all the way down, it's resistant to everything, most of those are going to be still susceptible to imipenem and cilastatin, okay? Vancomycin is the other one we just talked about, where this gets reserved for highly resistant bacteria, mostly gram-negative, like methicillin-resistant Staph aureus or Enterococcus, okay? All right, so another important group of drugs to have categorized as things that we don't give to food-producing species. This is just one of those lists that you need to keep for boards and keep for clinics when you come through the large animal hospital. But these are going to be medications that are either prohibited or restricted in some way. And when they're restricted, it usually means that they are only able to be given to the group of animals, so the specific age range or indication. So it might be that it's only labeled for use in bovine respiratory disease or in bovine foot rot. So this is where it becomes important to read the label, not something that you should be memorizing, but have a general understanding of what drugs are restricted and need to follow the label directions in terms of the indication, the dose, the route of administration, okay? So chloramphenicol is prohibited, the fluoroquinolones are restricted, glycopeptides are prohibited, and then the nitrofurans, nitroimidazoles are also prohibited. Cephalosporins and sulfonamide antibiotics and medicated feeds are all restricted. So those cannot be given any other way than how they're labeled, and for the frequency and the interval and everything. There's also a voluntary ban on aminoglycosides, which we talked about when we went through that, because they're so nephrotoxic to people and to all species, really. And then clenbuterol, diethylstilbestrol, and phenylbutazone are not antimicrobials, but they are on that list of medications that are prohibited or restricted in food animal species. And so that's just an important list to kind of have and look over again, especially when you're going to take your NAVLE. Okay, so kind of thinking back to the beginning, because when we are then trying to apply our knowledge of we kind of have an idea of what all these antimicrobial classes are and a general sense of what they do. How do I still know when to use them, and when do I even need an antibiotic? So we want to kind of ask these questions every time you're going to reach for an antimicrobial. So basically, when you think about when is administration of an antimicrobial justified, well, that's really easy if you have a proven bacterial infection. But you don't always have that. So there's other times when you have justification to use an antimicrobial, and good examples of that are when the patient is at a high risk of getting a bacterial infection. Patients that are very neutropenic, right? So those on chemo, those with other severe systemic diseases that cause them to be neutropenic are at an increased risk of getting a secondary opportunistic bacterial infection, and they might be it is justified in those cases to cover them with broad-spectrum antimicrobials until they're not in that critical situation anymore. So that would be short-term kind of prophylactic antimicrobial use. Another place where you guys know antimicrobial use is justified, but there's no infection, is again a short-term period around elective procedures. So when you are doing something to the patient, making a surgical incision, and even though you do all of your aseptic technique to enter that patient, make sure that the skin is clipped and prepped, you don't want to introduce bacteria, and you want an antimicrobial at the site of infection at the time you're making your incision and that you're at surgery. And so that's another indication for giving antimicrobials that you don't have an established infection. Okay, does that make sense? So sometimes we're using antibiotics when there isn't an infection, but when there's a high risk of introducing bacteria or there's a high risk of a secondary bacterial infection. So then we have to think about what's the clinical approach to empirical selection of antimicrobial drugs. Well, that's where your knowledge comes in over these 3 years and more that you're gaining, is what species am I dealing with? What part of the body am I dealing with? What are the most likely pathogens that I'm going to encounter here? There's going to be some diseases that have a really classic constellation of clinical signs that you could basically examine the patient and say, this is most likely kennel cough. I know kennel cough most likely is Bordetella. This patient is not getting better on its own with supportive care and needs an antimicrobial that's specifically effective against this particular bacteria. So getting a good history, physical exam, and understanding the clinical signs and what those most likely tell you is one way. And then other things you just need to kind of, again, think about your species. And we talked a lot about simple things like urinary tract infections. Across the board, everybody in here and all of the veterinary species that we deal with, they're likely to get an infection with gram-negative bacteria that's around the GI tract, right, just from proximity. So E. coli happens in people as well in terms of a urinary tract infection. That'd be a very common thing to culture. So there's certain areas that you're just going to have a list of the top pathogens that you're likely to encounter. And then thinking about what the antimicrobial drug is going to be doing in that particular patient. There's some drugs classes that we talked about, like the fluoroquinolones, that we would avoid in young, growing animals because of their effects on cartilage. So thinking about, is this particular class of drugs or drug I'm about to use potentially toxic to this patient for whatever that patient's circumstances are? If they're in renal failure, you're going to avoid at all costs what class? Aminoglycosides, yeah, absolutely. And then the same thing is, what is the patient doing to the antimicrobial drugs? So are they, thinking about where the infection is kind of really helps. And if there's any other, patient factors that are going to affect how that drug works. We're always kind of doing a risk to benefit assessment. So if I administer this medication, will I be doing more harm than good? And then thinking about the route of administration, the dosage, and seeing if it's appropriate for that particular patient and that client situation. There's going to be some times when you want to be able to give a drug 4 times a day, because that's what it's labeled for, that's how we know it's the most effective, but you know the client is not going to be able to do it 4 times a day, so you have to come up with another therapy that is going to have good compliance, because if you don't recognize that, then the only thing you're going to be doing is setting up the patient and the client for treatment failure, and that not only is very frustrating and potentially dangerous to the patient, but also will create a more hospitable environment for resistance to develop in those bacteria if they're not getting treated appropriately. And then thinking about, are there patient factors, infection factors that are likely to make the antimicrobial drug fail? And are there other therapies required for success? And this is a good example of when there is either necrotic tissue or sequestrum or an implant that's still in the patient that is got a biofilm on it. If we leave that in, we could treat them for 3 years with antimicrobials. And every time we take them off, they're going to have recurrence of that infection unless we remove that infected plate or whatever the implant is. How long do we treat is a very hard question to answer, something that you're going to have to figure out based on what the infection is, and that's going to definitely take longer clinical experience. There's not many infections that we routinely deal with that we have a set-in-stone number of days that we treat for. That's always going to depend on response to therapy, improvement of clinical signs, and usually improvement of any radiographic changes or blood work changes as well. And then finally, thinking about how do we actually interpret those culture and susceptibility results that we get back. This is something that across the board veterinarians struggle with. This is not just new graduates that struggle with this, but veterinarians that have been in practice for a long time. Dr. Credile is going to definitely go into this a lot deeper, but we're going to just generally talk about it here, okay? So the 2 methods for how we culture and get susceptibility information are through the disc diffusion method, okay, which is the Kirby-Bauer plate method, where you basically grow bacteria on a plate and you drop all these little discs that have different antimicrobials on them onto the plate, and you see which ones inhibit growth. So the ring or zone of clearance around those, depending on how wide it is, the wider they are, the more sensitive it is to that particular drug. You can see that this little guy right here, he's like, I don't care at all that antimicrobial is there, so not sensitive to that at all, right? Very resistant. This would be intermediate, and this would be more sensitive, okay? But this is not very sensitive method, okay? You're basically measuring this little zone of clearance, and again, this doesn't reflect, none of these tests reflect very well what's actually happening in the body, but it's the best that we have. The broth dilution assay gives us a little bit more information because it provides an actual concentration of antibiotic that either inhibits, so the minimum inhibitory concentration comes from this, and that's based on the sample turbidity, and it basically signifies the minimum concentration of the drug that reaches concentrations in the plasma to be effective against that bacteria. We do not have these breakpoints for all the pathogens that we see in veterinary species, and most of these are extrapolated from human data. And like I mentioned, what happens in vitro is not always going to equate to what happens in vivo. A good example of this is chloramphenicol. You're going to get pretty low plasma concentrations in the patient when you're giving it, but you're going to get really, really high tissue concentrations because it's so lipophilic. So it's going to be very effective against bacteria that are deep in the tissues, but you might not have those high concentrations of that drug in the plasma. So it might look like it's resistant to chloramphenicol on your susceptibility results because you can't reach that high concentration in the plasma, but you're getting those high concentrations in the tissue. So we're only looking at plasma levels with these methods. The CLSI breakpoint is just something that is a standardized Clinical and Laboratory Standards Institute, so a whole group of research scientists that basically come up with these and look at pathogens for both veterinary breakpoints and human, but there's just not as much data for veterinary pathogens. Okay, so now this is kind of what that minimum inhibitory concentration in the broth dilution looks like. So the darker the color of these test tubes, the more bacterial growth there is. So this is the zero drug in this first test tube. So there's rampant bacterial growth. And as you go along and increase the concentrations, you get less and less growth until it's clear, okay? So then what they do is plate out those ones where we start to see a reduction in the turbidity, and they're able to get the minimum bactericidal concentration. So what concentration of drug results in no growth from that broth dilution? And as you can see here, these are the minimum inhibitory concentrations. So at 4 micrograms per mil in the plasma, when you plate that out, no growth. So that's the minimum bactericidal concentration here. The minimum inhibitory concentration here is 2, where it reduces growth effectively, but there's still going to be some breakthrough. This is the bactericidal concentration and the minimum inhibitory concentration. So you see that clearing in the actual test tubes, okay? So some other things that are important to remember is that not every established bacterial infection is going to need systemic antibiotic therapy. A good example is strangle, so non-complicated strangles where they just have submandibular lymph node enlargement, fever, and kind of a upper respiratory infection. Those horses will clear that infection with supportive therapy on their own. A lot of times those abscesses will rupture and drain, and they will get really good immunity following that infection. If you administer antibiotics to those non-complicated cases, it will delay their abscesses from maturing and rupturing, and it will reduce their immunity to that to that bacteria going forward. So it's not always indicated, and they get better with just supportive care and things like NSAIDs and good feed and that kind of thing. The same thing, there's sometimes we can treat things topically where we do not need to give systemic antimicrobials. So topical therapy for some simple or superficial bacterial folliculitis cases. The same thing for some surgical site infections. If there are surgical site infections in the skin that we can open and drain, we don't often need to actually put them on systemic antimicrobials, and they often don't have fevers associated with that. They just have local drainage and inflammation. The other thing to remember is not everything you culture is clinically relevant. So you really have to think about where are we taking this culture from and what does it mean to this patient. If you went around and did nasal swabs in all your patients, you're going to grow bacteria, but if they don't have a respiratory infection, what does that mean to you? Probably nothing. If they have a pneumonia and you're sampling the nasal cavity, you're probably not getting the actual bacteria that's causing the pneumonia. So it's really important to think about where your culture is coming from and what it means in the context of the case you're treating. So a culture is only as good as the sample you've obtained and knowing what the animal's clinical signs are, the potential for that particular bacteria that you've grown to be pathogenic. So if you grow like an alpha strep, now I'm not saying you need to know this now, but there's going to be some commensals that you might grow from skin or from the nasal passages in light growth that are going to mean nothing. They're going to be contaminants maybe from your own skin getting into the bacterial culture. So the magnitude of growth is also important to take into account. And this is different depending on the site that you're taking the culture from. So if you're culturing, let's say the lungs versus the spinal fluid, what do you think would be more significant if you got light growth? If you thought you had pneumonia, you cultured the lungs, you got light growth of a pathogen, versus you cultured the spinal fluid and got light growth of a pathogen, what would be more problematic? What would give you more alarm? The spinal fluid. You should have nothing in there, no bacteria. But the trachea is open to the environment, right? So you can have some bacteria that are transient, you know, in the trachea, and you can get a perfectly normal horse and get light growth of bacteria. So always thinking about where am I getting this from? What's the magnitude of growth here? The other thing to remember, and I think we've talked about this quite a bit, is even the right antimicrobial can fail. And so I'm just going to leave it kind of at that. And we did definitely talk about how important it is to remove things that could be a nidus or a source of infection in these cases, and also thinking about the immune status of your patient. Why is my medication not working when I expect it to? Think about the whole animal. I have this summary slide to kind of look through the different antimicrobials, and this looks a bit messy, but I tried to put things together in terms of their spectrum of activity, and the key on the side where it says polar, moderately lipophilic, or highly lipophilic is up in the corner or on the side of each of the classes. So things in the middle are pretty broad spectrum. Metronidazole is at the bottom. It is broad spectrum but anaerobic, so it's special. The macrolides and lincosamides are the most similar in terms of spectrum of activity and mechanism of action, so they're in the same color. Rifampin has a pretty similar spectrum of activity but a different mechanism of action than the macrolides and lincosamides, so it's listed with them. So these are put up here to kind of group them in a way that makes sense in terms of some of their similarities, okay? Okay, so I want to just take the last few minutes. We only have 2 minutes to look through these case examples. So this should be a simple one. The dog presents with an uncomplicated urinary tract infection. You suspect a gram-negative enteric bacteria. What would be the first and best choice selection for oral antimicrobial therapy? So I've given you a lot of hints here because we're talking about only something that's oral. A gram-negative enteric bacteria in the urinary tract it's not an anaerobe, okay? What do you guys think? What would be the best selection? B, yeah, exactly. So by adding clavulanic acid in, you have more gram-negative spectrum. So this is the appropriate choice because of the spectrum of activity. You get high concentrations in the urine, and it's an oral option. The other answers are not correct because penicillin G is not absorbed, not bioavailable. C is not right because this is an aerobic bacteria. And D is inappropriate, right? It's a restricted antimicrobial. Second example here, 2-year-old horse with bacterial bronchopneumonia following a viral respiratory infection. You suspect an opportunistic bacterial infection, and the most commonly isolated bacteria is Streptococcus equi subspecies Zoepidemicus. What's the most appropriate antimicrobial therapy? This one's a little bit trickier. D, yeah. So D is correct because it's the appropriate spectrum of activity. It establishes adequate concentrations in the pulmonary epithelial lining fluid, and it's actually labeled for the horse for this particular pathogen. It is a beta-lactam antibiotic, very good against gram-positive aerobes, which Streptococcus zoepidemicus is. Enrofloxacin is not appropriate because it is inconsistent against strep. Fluorphenicol will cause fatal colitis. Chloramphenicol is an unnecessary selection of an antimicrobial with a high potential for toxicity to people. And so that means ceftiofur is the best choice. Does that make sense, or does that make you guys angry? Those questions. I really don't have anything that is this intricate. We're really going to focus on the big concepts, mechanisms of activity. But if you have questions after, again, if you've come to lecture and you've listened, I think you're going to be totally fine. I have the notes online on ELC to look through as well, to be extra reminders to read through if it's easier than being in lecture. And then the chart will help. If you fill that in, it'll just make you remember kind of what the classes are and what the specific things in each class are, okay? And I know this is a big, frustrating class, but this is so important, okay? And I'm very available, so if you need me to ask questions or don't understand something, and I know sometimes you don't know if you don't understand it until you get asked the questions, but please let me know. I'm happy to talk with you guys about this at any time. All right, sorry I went a little over today, but I get back from being early last week. Okay.
What's up?
Not much, how are you?
I'm fine. Glad to be serving the great state of Georgia and contributing to the education of young minds. Is that where you were also at?
I wish they liked it more. Sometimes I get sad.
I think they do. It's just we're throwing so much shit at them, watch them being recorded. I may be viewing this with rose-colored glasses, but I do think the new curriculum can make a difference.
It is what they are expected to learn in school. It could be its own.
Is seeing what I think, like, and I think there's going to be a lot of grassroots stuff. Say, I don't know if you teach equine GI or not, but whoever does, you know, we have us coming in, we're talking about parasite stuff at the same time.
Yeah.
We're make sure that we're saying the same thing, so there's not this disconnect.
Yeah. No, I think it's going to be better too. I mean, especially in a more of a clinical context, it's going to help you.
In parasitology, we're in that weird thing. We're not basic. We're in that middle thing, so we can still talk to y'all.
Yeah.
And it makes the link.
Right.
And plus, heartworm ain't going anywhere, so I know I have a job. See ya. Good seeing Aaron.